Hello, my name is Allison Borgsmiller, and I will be presenting the clinical practice guidelines for community-acquired pneumonia in the pediatric population. In this presentation, we will be discussing the clinical practice guidelines for the management of community-acquired pneumonia in infants and children older than 3 months of age, based on the recommendations made by the Pediatric Infectious Disease Society and the Infectious Disease Society of America. And why do we need clinical practice guidelines for community-acquired pneumonia? That is exactly the question we attempt to answer in this presentation. The patient population we will be discussing in this presentation involves the evaluation, diagnosis, and management of community-acquired pneumonia in healthy infants and children in both the outpatient and inpatient settings. Community-acquired pneumonia is common and a serious infection with an estimated 1.2 million children diagnosed in the primary care setting annually. Evidence-based clinical practice guidelines were established as a goal of decreasing morbidity and mortality related to community-acquired pneumonia in otherwise healthy children and increasing appropriate antibiotic use. Despite these guidelines, there is significant variability in antibiotic prescribing practices among providers. Clinical practice guidelines are statements systematically developed intended to assist practitioners and patients in making decisions regarding healthcare for specific clinical situations. This includes a multidisciplinary process which is valid, reliable, reproducible, applicable, flexible, clear, has a thorough review of evidence obtained, and also has well-documented results. Community-acquired pneumonia in children is typically caused by a viral or bacterial infection. Confirmation of the underlying infection of pneumonia can be difficult, with no definitive test to distinguish if it's bacterial or non-bacterial in origin. With treatment, most types of bacterial pneumonia can be cleared within 2 to 4 weeks. This presentation primarily will be discussing guidelines related to the pediatric population in an outpatient setting, but will also include guidelines related to the inpatient setting, especially to identify children diagnosed with community-acquired pneumonia that require hospitalization. The recommendations to hospitalize children includes children and infants with moderate to severe community-acquired pneumonia, which have several factors, including respiratory distress and hypoxemia, should be managed in the hospital. Infants less than 3 to 6 months of age with suspected bacterial community-acquired pneumonia are likely to benefit from hospitalization. And children with suspected or documented community-acquired pneumonia with a pathogen of MRSA should also be hospitalized. In children and infants who there is a concern about careful observation at home or who are unable to comply with the therapy recommended should also be followed up within the hospital. Clinical practice guidelines 5 through 11 are specific to when a child should be admitted to the ICU related to community-acquired pneumonia. If a child requires invasive ventilation via a non-permanent artificial airway, a child should be admitted if they require continuous cardiorespiratory monitoring, if they have impending respiratory failure, if they have sustained tachycardia, inadequate blood pressure, or need for pharmacological intervention to support blood pressure or perfusion, if they have a pulse oximetry measurement of 92% or less on oxygen, if they have altered mental status due to lack of oxygen as a result from pneumonia, and in the context of other clinical, laboratory, or radiological findings. Blood cultures should not be routinely performed on non-toxic, fully immunized children with community-acquired pneumonia managed in the outpatient setting. Blood cultures should be obtained in children who fail to demonstrate clinical improvement and those who have progressive symptoms or clinical deterioration after initiation of antibiotic therapy. Blood cultures should be obtained in children requiring hospitalization for presumed bacterial community-acquired pneumonia that is moderate to severe, particularly those with complicated pneumonia. Repeat blood cultures to document resolution of bacteremia should be obtained in children with bacteremia caused by Staph aureus, regardless of the clinical status. Urinary antigen detection tests are not recommended for the diagnosis of pneumococcal pneumonia in children because false positive tests are common. Sensitive and specific tests for the rapid diagnosis of influenza virus and other respiratory viruses should be used in the evaluation of children with community-acquired pneumonia. A positive influenza test may decrease both the need for additional diagnostic tests and antibiotic use, while guiding appropriate use of antiviral agents in both the outpatient and inpatient settings. Antibacterial therapy is not necessary for children either in outpatient or inpatient settings, with a positive test for influenza virus in the absence of clinical, laboratory, or radiological findings that suggest bacterial co-infection. Diagnostic testing for chlamydophila pneumonia is not recommended as reliable and readily available and does not need to be used as a diagnostic test in the clinical setting. Weak recommendations related to complete blood cell count. Routine measurements of complete blood cell count is not necessary in all children with suspected community-acquired pneumonia managed in the outpatient setting, but those with more serious disease, it may be helpful for clinical management in the context of clinical examination and other laboratory and imaging studies. A complete blood cell count should be obtained for patients with severe pneumonia or be interpreted in the context of full exam and other laboratory and imaging studies. Acute phase reactants such as ESR, C-reactive protein, and PCT cannot be used as a sole determinant to distinguish between viral and bacterial causes of community-acquired pneumonia. Acute phase reactants need not to be routinely measured in fully immunized children with community-acquired pneumonia who are managed as outpatients, although for more serious disease, acute phase reactants may provide useful information for clinical management. Pulse oximetry should be performed in all children with pneumonia and suspected hypoxemia. The presence of hypoxemia should guide decisions regarding site of care and further diagnostic testing. Routine chest x-rays are not necessary for the confirmation of community-acquired pneumonia in patients well enough to be treated in the outpatient setting. Chest x-rays, posterior, anterior, and lateral, should be obtained in patients with suspected or documented hypoxemia or significant respiratory distress and those who failed initial antibiotic therapy to verify the presence or absence of any complications of pneumonia, including effusions, necrotizing pneumonia, and pneumothorax. Chest x-rays should be obtained in all patients hospitalized for the management of community-acquired pneumonia, documenting the presence, size, and character of infiltrates and identifying complications of pneumonia that lead to intervention beyond antimicrobial agents and supportive medical therapy. Repeated chest x-rays are not routinely required in children who recover uneventfully from an episode of community-acquired pneumonia. Repeated chest x-rays should be obtained in children who fail to demonstrate clinical improvement and those who have progressive symptoms within 48 to 72 hours after initiation of antibiotic therapy. Routine daily chest x-rays is not recommended in children with pneumonia complicated by effusions, chest tube placement, or assisted thoracoscopy surgery, and if they remain stable. Follow-up chest x-rays should be obtained in patients with complicated pneumonia, worsening distress, or clinical instability, or those with a persistent fever that is not responding to therapy in over 48 to 72 hours. Repeat chest x-rays 4 to 6 weeks after diagnosis of community-acquired pneumonia should be obtained in patients with recurrent pneumonia involving the same lobe or patients with lobar collapse in initial chest x-ray with suspicion of atomic anomaly, chest mass, or foreign body aspiration. What are some additional diagnostic tests that should be done with a child with severe or life-threatening community-acquired pneumonia? The provider should obtain tracheal aspirates for gram stain and culture, as well as clinically and epidemiologically guided testing for viral pathogens, including influenza virus, at the time of initial endotracheal tube placement in children requiring mechanical ventilation. Which anti-infective therapy should be provided to children with suspected community-acquired pneumonia in both outpatient and inpatient settings. Antimicrobial therapy is not routinely required for preschool-age children with community-acquired pneumonia because viral pathogens are responsible for the greater majority of clinical disease. Amoxicillin should be used as the first-line therapy for previously healthy, appropriately immunized infants and preschoolers with mild to moderate community-acquired pneumonia suspected to be of bacterial origin because it appropriately covers for Streptococcus pneumoniae. Ampicillin or penicillin G should be administered to fully immunized infants or school-age children admitted to the hospital with community-acquired pneumonia when epidemiological data lacks substantial high-level penicillin resistant for invasive Streptococcus pneumoniae. Vancomycin or clindamycin should be provided in addition to B-lactam therapy if clinical, laboratory, or imaging characteristics are consistent with infectious caused by Staph aureus. Antibiotic exposure selects for antibiotic resistance. Therefore, limiting exposure to any antibiotic is preferred whenever possible. Limiting the spectrum of activity of antimicrobials to that specifically required to treat the identified pathogen is preferred. Using the proper dose of antimicrobial to be able to achieve a minimal effect concentration at the site of infection is important to decrease the development of resistance. Treatment for the shortest duration possible will minimize exposure to both pathogens and normal flora and minimize the selection for resistance. Treatment courses of 10 days have been best studied, although shorter courses may be just as effective, particularly for more mild disease management in the outpatient basis. Infectious causes by certain pathogens, notably MRSA, may require longer treatment in those with Streptococcus pneumoniae. Pediatric patients on adequate therapy should demonstrate clinical and laboratory signs of improvement within 48 to 72 hours. For children whose condition deteriorates after admission and initiation of antimicrobial therapy or who show no signs of improvement within 48 to 72 hours, further investigation should be performed. History and physical exam may be suggestive of parapneumonic effusion in children suspected of having community-acquired pneumonia, but chest X-ray should be used to confirm the presence of pleural fluid. If chest X-ray is not conclusive, further imaging is required like a chest ultrasound or CT. The size of the effusion is an important factor that determines the management. If the child's degree of respiratory compromise is an important factor that determines management of parapneumonic effusions. Gram stain and bacterial culture of pleural fluid should be performed whenever pleural fluid specimen is obtained. Antigen testing or nucleic acid amplification through PCR increase the detection of pathogen in pleural fluid and may be useful in management. Small, uncomplicated parapneumonic infusion should not routinely be drained and can be treated with antibiotic therapy alone. Moderate parapneumonic effusions associated with respiratory distress, large parapneumonic effusions, or documented purulent effusion should be drained. Both chest thoracostomy tube drainage with the addition of fibrolytic therapy in VATS have been demonstrated to be effective methods of treatment. Both the choice of drainage procedure depends on the localized expert. Both of these methods are associated with decreased morbidity compared with chest tube drainage alone. However, patients with moderate to large effusions that are free-flowing, placement of the chest tube without fibrolytic agents is a reasonable first option. VAT should be performed when there is persistent of moderate to large effusions with ongoing respiratory compromise of 2 to 3 days of management with chest tube and completion of fibrolytic therapy. Open chest tube debridement represents other options for management of these children, but is associated with higher morbidity rates. After primary drainage of VATS, a chest tube can be removed in the absence of an thoracostomy air leak when the pleural drainage is less than 1 ml per kilogram in 24 hours, then calculated over the last 12 hours. When blood or pleural fluid bacterial culture identifies the pathogen, antibiotic susceptibility should be used to determine antibiotic regimen. In the case of culture-negative parapneumonic effusions, antibiotic selection should be based on the treatment recommendation for patients hospitalized with community-acquired pneumonia. The duration of antibiotic therapy depends on the adequacy of drainage, on the clinical response demonstrated for each patient. In most children, antibiotic treatment for 2 to 4 weeks is adequate. Children who are not responding to initial therapy after 48 to 72 hours should be managed by clinical and laboratory assessment of the current severity of illness and anticipated progression in order to determine whether higher levels of care or support are required. A BAL specimen should be obtained for gram stain and culture for the mechanically ventilated child. A weak recommendation, but something to consider if a pulmonary absence or necrotizing pneumonia identifies a non-responding patient can be initially treated with intravenous antibiotics. Well-defined peripheral abscesses without connection to the bronchial tree may be drained under image-guided procedures either by aspiration or with catheter drainage that remains in place. But most abscesses will drain through the bronchial tree and heal without surgical or intervention. Hospitalized patients with community-acquired pneumonia can be safely discharged when there has been documentation of overall clinical improvement, including level of acuity, increase in appetite, decreased fever for 12 to 24 hours, demonstrate continuous pulse oximetry measurement of above 90% in room air for at least 12 to 24 hours, demonstrate stable and baseline mental status. Patients are not eligible if they have increased work of breathing or sustained tachypnea or tachycardia. Patients should also have documentation that they can tolerate their home anti-infective regimen, whether it's oral, intravenous, and home oxygen if applicable. For children who have chest tube that meets requirements listed above, hospital discharge is appropriate after the chest tube has been removed for 12 to 24 hours, and there is no clinical sign of deterioration since removal of the chest tube. Obtained for clinical concerns if no concerns of reaccumulation of parapneumonic effusion or pneumothorax. It is strongly recommended conversion to oral outpatient step-down therapy when possible is preferred to parenteral outpatient therapy. Children should be immunized with vaccines for bacterial pathogens including Streptococcus pneumoniae, Haemophilus influenza type B, and pertussis to prevent community-acquired pneumonia. Infants 6 months of age and all children and adolescents should be immunized annually with vaccines for influenza virus to prevent community-acquired pneumonia. Parents and caretakers of infants 6 months of age, including pregnant adolescents, should be immunized with vaccines for influenza virus and pertussis to protect the infants from exposure. Pneumococcal community-acquired pneumonia after influenza virus infection is decreased by immunization against influenza virus. High-risk infants should be provided immune prophylaxis with a specific RSV antibody to decrease the risk of severe pneumonia and hospitalization caused by RSV. References for the presentation are provided below, and also a handout will be included with the presentation as a guide for providers related to community-acquired pneumonia in the pediatric population.